good morning. It's really nice to be here. Thank you for having me. As Dr. Lambert said, I am a psychiatrist here at Indiana University. I have a special training in treating patients who have mental health problems in addition to medical problems. So this type of work is right up my alley. Now that I've said that, I'm going to make the caveat that in the past, we've always thought of mental health being over here and physical health being over here, and the two don't mix. And that is changing significantly over the last few decades because we're understanding more and more that how you're doing mentally has a great deal with how you're doing physically. Maybe a relevant example to some people here is that people who have a liver transplant have a greater risk of mortality if they have depression. So psychiatrists have become really interested in trying to help control diseases like depression and anxiety in patients with serious medical illnesses because we know that those illnesses, depression and anxiety, make outcomes worse. So I hope you'll keep that in mind as we talk through this lecture. I'll also say that just to get to my objectives, we'll talk about depression and anxiety. We'll talk about how they are impacted by autoimmune hepatitis, as well as some medication and non-medication strategies for addressing depression and anxiety. And I'll also give you some helpful resources so that if you have more questions or concerns that you can go look things up after you leave. So I'm going to start with the confession that I hate being on a flight and having the stranger next to me ask what I do. Because people have impressions of psychiatry that have been very much influenced by media. In the best case scenario, we're perceived as kind of empty people who are just interested in like voyeuristically listening to people's childhood traumas. In the worst case scenario, we're sometimes perceived as pill pushers or as people that lock people up in institutions and put them in straitjackets. So the media hasn't always been kind to psychiatrists. And I wanted to emphasize this because really in real life we're normal doctors. We look and act like your other doctors. We go into psychiatry because we care about people and we care about hearing people's stories. And so if you ever have a doctor that recommends you see a psychiatrist, I want to try to reduce some of the anxiety around that because I know that can feel lots of different ways for people. But we're good people. We do have a little more time to devote to these problems than your other doctors might. And so in that way, we might get to know you a little bit better, and we might have the opportunity to make adjustments to your medicines that your other doctors might not have thought of. I also wanted to emphasize that in the movies, the patients, or in the media, patients who see psychiatrists can be portrayed very negatively. In the worst case scenario, they're sort of evil. The vast majority of people that I see are just everyday people across all, I see poor people, I see wealthy people, I see all kinds of people. So if your doctor suggests that you see a psychiatrist, that's not a judgment about you. At all. So I'm going to start by talking about depression. Depression is very, very common. Studies differ, but there are estimates of about 10 to 20% of people will experience depression at some point in their life. We also know that it's horribly undertreated. So if you have 10 patients that have depression, 2 of them will get treatment from their primary care provider. Another 2 of those patients will get referred to a mental health provider, but 1 of them won't go because we're scary. And then 6 patients of those 10 will get no treatment at all. So 6 to 7 out of 10 patients, so 60 to 70% of people are not getting treated for depression. Depression can affect anybody. Like I said, I see all kinds of patients from all walks of life. I see very hardworking, very intelligent people that struggle with depression. And I use this slide because Abraham Lincoln famously struggled with depression. We don't know the exact cause of depression, but the current hypothesis is that there is some genetic vulnerability combined with some kind of environmental stressor that comes together to create depression in an individual. And symptoms of depression can include low mood, loss of interest in things, withdrawal from friends and family, low energy, difficulty concentrating, changes in sleep, appetite, hopeless feelings or wanting to give up. Anxiety is also very common, and probably 15 to 20% of people experience anxiety at some point in their life. I'm going to say that 100% of people experience anxiety at some point of their life. It is very normal to have anxiety. If we didn't get anxious when we were in dangerous situations, we wouldn't protect ourselves. So it's important to recognize that we all experience anxiety, but an anxiety disorder is when that anxiety gets in the way of us doing what we need to do. Oprah has famously come out to talk about her own struggles with anxiety. And here's some symptoms of anxiety that you may have experienced: worrying constantly, feeling tense or on edge, trouble sleeping, panic attacks, feeling tense in your muscles, stomach aches, headaches can all be signs of anxiety. So what does this have to do with autoimmune hepatitis? So we know from studies that have happened over the last 4 or 5 years that patients with autoimmune hepatitis are at increased risk of depression, increased risk of anxiety, and have a lower quality of life compared to other individuals. I wanted to open it up and see if anybody had any thoughts on why that might be. Yes. Yeah. So like fatigue and like just physical discomfort. Mm-hmm.
So beyond the symptoms, anything else with the disease? I think this is a good point. I think about this often. I always think about inflammation and general kind of neuro-liver axis stuff.
Well, yeah, I was going to say, I imagine basically if you have the autoimmune hepatitis, your body isn't working correctly. So then that's going to screw other things up because everything's connected.
Mm-hmm. Yeah, so autoimmune disorders in general are associated with higher levels of depression and anxiety.
Yeah.
I feel like since we don't really look sick a lot of times, people misunderstand it.
Uh-huh.
That really makes it hard.
Yeah, that's not something that I got. So on my next slide, I talked about some of these reasons why we might see greater depression and anxiety in patients with autoimmune hepatitis, and that's a very good point. Stigma, I mentioned stigma, and I was thinking about stigma more in terms of having a liver disease. People might assume that you're an alcoholic, and so it may be difficult to talk about your liver disease with people who don't understand it. But I think that's also a very important point, that if you have a sort of an invisible disease, people don't really understand what you're going through. That can be true of depression and anxiety too. I wanted to highlight that some of the treatments for autoimmune hepatitis can cause depression and anxiety. Steroids are famous for causing depression and anxiety. In higher doses, they're more likely to cause anxiety and difficulty sleeping, but in low chronic doses, they tend to have a depressant effect. Obviously, you shouldn't come off your steroids for these reasons. But if you're noticing depression and anxiety, there are other medicines that can help you deal with the symptoms. I also mentioned the financial stress and just generally worrying about your health. Like if you have a chronic medical condition, you're probably worrying about your health frequently. So I wanted to talk some more about the treatment of depression and anxiety. Here I am highlighting some of the non-medication strategies for combating depression and anxiety. Again, the stereotype is that psychiatrists are constantly pushing medicines, but we'd love for our patients to take non-medication strategies to improve their mental health. I find that exercise can be especially helpful for anxiety, difficulty sleeping, and fatigue. I recommend that patients have a regular routine, so getting up at a regular time in the morning, going to bed at a similar time each night, trying to get sufficient sleep. Participating in fun activities or hobbies like gardening, walking. Avoiding alcohol and drugs, which can influence your mood and your anxiety levels, and getting therapy. So therapy can be very helpful. Many people think that therapy is going to a doctor laying on the couch talking about everything that happened in your childhood, when actually most people who get therapy are doing therapy in a very much here and now problem-focused strategy. Like, what can I do now to make things better in my life? I also recommend that my patients reach out and develop a social support network. So you don't have to tell your family or friends exactly what you're going through, but just having people around you can be helpful and diminish that isolation. And then, of course, there are people who those non-medication strategies will not be enough, and people will need medications. Medicines for depression are effective. Some common myths are that they change your personality or that they're a happy pill. They don't change your personality, and you're not going to feel happy when you start taking these medicines. Most of my patients say they just feel less sad or less worried. Antidepressants are the treatment of choice for both depression and anxiety. Interestingly, antidepressants have been found to be effective in a lot of different conditions. So pain syndromes, irritable bowel syndrome, fibromyalgia, migraines, and smoking cessation all have antidepressants that can be helpful in treating them. And that's even amongst people who are not being treated for, who don't have depression. So fibromyalgia pain responds to certain antidepressants even if the patient is not depressed. There was recently a study that showed that antidepressants change the bacteria in your intestines, and there's some thought that that might be part of the way that they work. We don't fully understand the way that they work, but I think that's just more and more proof that somehow our brains and our bodies are very much connected, and this mental health and physical health silos they just don't apply anymore. So here I have included some common antidepressants. These are the ones I use most commonly. These are all trade names or brand names, but of the medicines here, they all have generics available, and I always prescribe generics because there's not really any evidence that the brand name is more effective than the generic. So the generic are less expensive. There are some newer antidepressants that you may hear about. They act the same way as these antidepressants, and they're no more effective, but they're much more expensive. So I hardly ever prescribe them. So you can go with the cheap medicines here. So for patients who are getting started on an antidepressant to treat depression or anxiety, this is a rule that I remind my patients of: 2-4-6. So most I shouldn't say most, some people will have side effects when they start an antidepressant. Those side effects are usually nausea or headache. They tend to be mild, and they tend to go away in a couple of weeks. So I ask my patients, please just hold out for 2 weeks and see if these side effects get better. Then around 4 to 6 weeks is when I expect to see a difference in how somebody's feeling. So if a patient tells me at 3 weeks that they're not feeling any better, I'm going to say that's not unexpected. Just hold on a little longer, because we may see some effect in a few weeks. And then I recommend that patients stay on their medicines at least 6 months, but preferably a year. We know that people who stay on their medicines for that long are less likely to relapse and have another episode of depression. Also, when people have had 3 episodes of depression, they tend to need to stay on medications long term. So most people respond to antidepressants. Unfortunately, we know that out of 3 people who take an antidepressant, a first antidepressant, that only one of them is going to get resolution of their depression, which is pretty discouraging, especially after a patient's been waiting for 6 to 8 weeks to see if the medicine's effective. This is discouraging, but it's also a place for me to point out that though all of the medicines work about the same, for each individual patient, one medicine may be more effective than another, and so we have to try another medicine. And that's another good reason to be working on some of those non-medication strategies to cope while you're waiting on the medicine to kick in. There are some other medicines for anxiety that I'm going to mention here. I will say that the antidepressants are the top choice for treating anxiety, but you may have heard of or have seen these other medicines like buspirone, hydroxyzine, or a class of medicine called benzodiazepines that are known as like Ativan, Klonopin, Xanax, Valium. I really don't recommend the benzodiazepines. So one of my colleagues says they make you feel better, but they don't make you get better. And we can talk about that more if you have questions. And I have a handout for all of you after the talk is over, and that includes some more information there. So if you're sitting here thinking, maybe I have depression or anxiety, and I would really like to manage it better because managing my anxiety and depression is going to help me manage my autoimmune hepatitis, I suggest you make an action plan. So I would start by making a daily routine. Choose one non-medication strategy to implement into your routine. So maybe going for a walk each day or connecting with a friend each day. Do reach out to somebody. Connection is so important. Review the resources that I'm going to give you for depression and anxiety if you have more questions or want to learn more. And then schedule a visit and talk to your doctor about it. Again, these problems are very, very common, but because there's been so much stigma around mental health, people aren't talking about it. So you may feel that what you're dealing with is very strange or unusual or different than anybody else could understand. But these are actually very common things that we just don't talk about often. Here are some resources. These will be included in the handout. So the National Alliance on Mental Illness is a good resource, as well as the Substance Abuse and Mental Health Services Administration, SAMHSA, and then a couple hotlines for questions about getting access to mental health treatment or a suicide talk line. So I wanted to just summarize by saying that psychiatrists are not scary people. We want to be helpful. Depression and anxiety are very common, and especially among people with autoimmune hepatitis. They're treatable. The treatment can take some time, but they are treatable. And both behavioral strategies and medications can be effective. And if you think that you have depression, develop an action plan, and specifically talk to your doctor about it. Thank you very much.
So I think that was great and clear and concise and really perfect for this audience. Can I start off maybe just a Q&A just a little bit with Dr. Holmes, if you will? One struggle I have as a hepatologist is the patient I see in clinic is complex, on a lot of medications. Their primary care doctor is scared of them in some sense and really doesn't want to make any changes or do anything different without the hepatologist's blessing. So the paradigm is I often become a primary care doctor in my own right.
Yes.
However, if I've ever shared with any of you, I'm not smart enough to be a primary care doctor, or at least a good one. So as a hepatologist perspective, and again, as patients working with gastroenterologists or hepatologists, how do you bridge that gap? And again, getting that referral to psychiatry and overcoming that barrier, because I feel like there is a lot of resistance among my colleagues to kind of dive in. And I will be completely honest, even here at Indiana University, I don't know really how to plug patients into psychiatry well.
I feel like there are a lot of things that I wanted to comment based on that. One is that getting access to psychiatry services can be very challenging, and it depends on where you are in your community. So yes, I definitely acknowledge that difficulty. Two is that this has been a problem that people have started to recognize over the last 20 years, and there are now clinics that pull a psychiatrist into the clinic. So it could be a liver clinic, it could be a cancer clinic, and because of this recognition that mental health problems affect physical health problems, there's more and more pull for psychiatrists to be where the patients are. That's not everywhere yet, and that's not going to help everybody yet. But I think that's a good move that you'll continue to see over the next few decades.
I think in our clinic, we do have GI psychology there. And again, if I ever want to have a patient seen there, I think the wait list is probably at least 3 to 6 months. And by the time, again, the dope that I am, I've realized that need exists. It's almost too late. So again, I think if we can push the kind of awareness of this in our patients, I ask a lot more. Again, I'm silly because I asked the first question is, well, how are you doing? It's a much deeper question than that, and I think I'm trying to encompass these pieces. I should be more specific. But again, if your doctor's not asking that question, I mean, I think, again, we want you as patients and folks associated with us to be driving those conversations, not only with fatigue and management of your liver disease, but you know what? I think I may have an anxiety disorder, or I may have really severe depression that's impacting my quality of life. Anybody have any questions? Oh, plenty, okay.
Hi, I actually have 2 questions. If a patient uses an SSRI and feels better but then has a blunted affect and doesn't want to take it anymore, clinically, what is your approach? Do you try a different one? Do you try an SNRI?
So I'm going to translate your question.
Sure, sorry.
So the SSRIs are the most common antidepressant that we use. And she was talking about the side effect where a patient is less expressive, and what a lot of patients will tell me is that they feel like they lose their feelings on antidepressants. And sometimes that's okay, and sometimes that people really don't like that feeling. And if they're not going to take the first thing that we try, I certainly will try something different and in a different class of medicine.
In a different class, okay. My second question is, you mentioned that study about the gut connection. Is there anything to warrant or suggest that supplementing with probiotics is a good idea? I mean, I think everyone should take them, but
There's been so much interest in probiotics for all kinds of things, and I don't know the research well enough to know if there's data to support that for depression or anxiety.
okay.
But I think that people are studying that actively.
Okay. Thank you.
One more question.
Yeah, thank you for the information. This was really great to hear. also kind of just want to comment as well. I'm a clinical psychology doctoral student, and just working in health psychology, and just want to make you guys aware as well that there are health psychologists and psychologists in particular that work with patients that have chronic medical conditions like all of us, and so they are kind of hard to find. And some tips I give patients when trying to find health psychologists is actually just to go on Psychology Today. It's a website. You can type in your insurance information, your location, and then also certain specialty areas that us as psychologists have, and one of those is chronic medical conditions. So you can actually work with someone that has knowledge in working with patients with chronic medical conditions. It might not be AIH exactly, it probably won't be AIH exactly, but at least they have the knowledge about how chronic medical conditions impact our daily lives, our quality of life, and anxiety and depression.
Thank you for saying that. My talk was very psychiatry-centric, but there's certainly lots of therapists and psychologists who are available to help with these problems.
Great. Thank you so much. Appreciate it.